We were trying to think of something that's very relevant to us for early career physicians. And, I think in the last year, we kind of seen that our field of medicine is not as bulletproof as we thought. All across the nation, some of my colleagues took 20-30% pay cuts. Some of them didn't have shifts to work, and some of the local doctors here, I mean, just were struggling. And even now we're left with huge patient volumes. It's just very tiring. We thought maybe 2021 would be a better year, and it's probably not starting much different from last year. So we wanted to just kind of, it's not one that we physicians like to talk about how we're doing personally. And I think we've been trained to just keep everything inside and not really kind of talk about things openly, which I think gives our profession a really high risk of burnout. So we've gotten a variety of different speakers here. We have Blake Hines, who's a hospitalist in Aberdeen, Matt Stanley, a psychiatrist in Avera, Sioux Falls, and I have Jennifer Williamson. I think Jennifer just joined in. She's Monument Health primary care specialist. And we just wanted to have a good discussion and different perspectives into how physicians in different types of fields are dealing with this pandemic, dealing with having a healthy mindset, and how we can keep staying in this profession, not burn out and leave it prematurely. So the format here is we're going to kind of just Clarissa and I are going to be asking questions, start some dialogue, and any of the guests here or anyone who joins in the webcast, put some chats in the comments, and we can definitely ask those questions. All right.
Yep. So I'll do the housekeeping stuff. So we are recording it because I know that there are people, especially with internists, a lot of hospitalists working at sort of weird hours. And so people who can't be here wanted to be able to watch it in the future. So just know that. It also means that if you have questions and you want to ask, but you don't necessarily want to be the one asking, you can also send them privately to either Eric or myself, and we'll ask for you. Though certainly Eric and I also have lots of prepared questions for common things that we're hearing as well. So maybe why don't we start like letting people sort of give some opening remarks? Should we do that, Eric?
Yeah, I think it'll be nice for our panelists maybe to introduce themselves. Yeah. Dr. Hines, do you want to start?
Sure. So my name is Blake Hines. I'm working out of Avera, St. Luke's out of Aberdeen, South Dakota, with the hospitalist program here. And I've been working here for about 5 years, almost 6, I should say. And we have a 5 to 6 person strong hospitalist group, so a pretty small group here that I'm the director of medicine for. So we've been pretty heavily involved, of course, with the COVID situation here on the inpatient side. And interestingly enough, have been looked at as sort of a source of information for the clinicians as well. I grew up in Aberdeen, so I'm just happy to be back working with a community that I know well, with a lot of friends and family that I know.
All right. Dr. Stanley, you want to give your intro?
Yeah, thanks, Eric, and good evening to everyone. Just finished supper myself, Eric. You're probably not appreciating that. I'm sure you haven't had a chance yet.
Not yet.
Anyway, Matt Stanley, I'm a psychiatrist. I'm here in Sioux Falls with Avera Behavioral Health. I've been with Avera for about getting pretty close to 25 years. So I've done just about everything in my clinical practice over the years. The last few years, I've been the vice president of our behavioral health service line. So over the course of my career, a lot of different hats, a lot of different duties and responsibilities. And in the last several years, probably more toward administrative stuff, things like access, quality, integration, some of those things that we're working on at a service line level. Clarissa and I have talked about physician wellness quite a bit. We've both kind of held some different roles within Avera in addressing that. And we've had this discussion about physician wellness and burnout. Increasingly, it feels like over the last couple of years, something we're all becoming more aware of. COVID, I think, has spiked this even a bit more. And I'm sure Eric, Blake was certainly referencing that. And I can tell you honestly, in behavioral health, just a personal aside, we almost feel guilty. We're very busy, but we don't feel like we're having to go through some of the traumatic environments that we feel our colleagues doing. We've been mostly in a supportive role. COVID has impacted us. We anticipate we're the third wave of COVID. So we've had one surge, two surge, third surge. We think will probably be a behavioral health. Although who knows, we've got new strains of COVID out there. I don't want to be the downer here. We're talking about wellness, so let's keep it on the up and up. But anyway, I'll stop there and I look forward to the conversation. Thank you.
Me too. And Jennifer, you want to give your intro?
Hi, I'm Jennifer Williamson. I'm working at the Rapid City Monument Health System. I've been with them since 2018. Prior to that, I was with the Avera Health System working out of Brookings, South Dakota. 5 years post-residency in internal medicine. Previously, I was doing the combination of hospital work as well as outpatient. Now I'm only doing the outpatient work, so I can devote more time to just focusing on one area of medicine as well as more time with family.
All right. Well, thank you for your introduction. So, I think the main question is burnout real? Some people are naysayers to this whole concept of burnout, and to different groups of people, you get different answers. To administrators, of course, they don't truly believe this is real, but what are your thoughts? Anyone have stab at it?
I was trained in the British. Yes, Eric, I was trained on the British system, and I know with our Joint Commission and all that, there have been regulation in the United States for quite some time in terms of the number of hours. So I'm quite familiar with the concept of burnout in that sense, although there is no label attached to it under the British system. So it's not unusual for, say, when I was an intern, to go to work on Friday morning and know that I'm not coming off until Monday afternoon. I remember one day as an intern, I was doing internal medicine rotation, and I went on Friday, and you have a little makeshift room that they call a lounge, that you go and you have your snacks and all that, and then you can so-called take care of your hygienic needs of some sort so you don't smell offensive to the patients. But I remember by Monday came around, the attendant was having a lunch, and he expected us to be answering all the questions. Oh, you could finish medical school, you guys should be sharp and all that. And I literally stood there and watched him being blurred, like edges around him were blurred, like he was having a halo. And I was realizing, okay, I'm about to pass out, quite blurred, quite tired, and still trying not to seem as underperforming. So you're still trying to answer questions, and I'm thinking, this cannot be good. This really cannot be good. Right. So in that sense, it does exist. I've seen people pass out on ward rounds, but no one really want to talk about it at that time, or no one wanted to talk about it then in the early to mid 2000s. In the past 5 to 10 years, people have been speaking more about burnout, because they're realizing that it's really affecting people. And on even a more personal note, a friend of mine who I trained with in New York, who was in the emergency room, he was burnt out to the point where none of us realized how much he was burnt out. And he took his own life 2 years ago. So it's something real, something I've seen up close and personal, especially being trained in New York and in the Caribbean under the British system. Quite real.
Well, that's like the most extreme effect of burnout, leading to a cascade of depression that you just don't have any more coping strategies. And that's the worst case that we're trying to avoid here. Dr. Stanley, is there an official definition of burnout that exists?
Yeah, there's some definitions, and I think it's pretty well recognized, at least we talk about the three main characteristics: the depersonalization, the loss of self-efficacy, and the emotional burnout. So the emotional just emotionally overwhelmed. So I think there are actually pretty well recognized definitions of burnout. And then Eric, you mentioned depression, which is sometimes we use those a little bit interchangeably. They're not entirely, but they certainly have a lot of crossover. One can lead to the other, vice versa. They can also exist independently. But it's interesting too. I just want to comment. I really appreciate Jennifer's personal comments and her own experience. And it's interesting that within medical training and the medical educational system, both here and in the United Kingdom, that we would have kind of similar problems in that, you mentioned administrators maybe not recognizing it, but I would say kind of like our entire medical culture has kind of avoided the concept. And I'm not disagreeing with you about administrators. I would say increasingly, at least we as a profession are recognizing it amongst each others. I don't know that that's a universal acceptance or recognition yet, but I think one of the toughest parts of this challenge for us as physicians is, we have a culture and kind of inculcated in us from the day one of medicine to just step up, do your job, you're next up, so get in there and take it, and work until the work, stay on the job until the work is done. So everything else becomes second to your professional responsibilities, including your needs, your family needs. And it's exactly those kind of pressures that lead to burnout. So to your question, burnout is pretty well defined, and there's actually some well-validated measuring tools. Maslach is the kind of the biggest, the BMI, or I'm sorry, MBI. Too much medical jargon and terminology. I am sorry. So there we go. But yeah, the Maslach burnout inventory. I must be a little burned out, tired, whatever. So okay, there you go, Eric. So burnout leads to medical errors. So let's just get that out of the way. I just made it. I'm gonna own it, and then we're gonna move on. But no, there are some other burnout inventories, and the AMA and some of our professional societies have recognized this. The AMA in particular, I think, is using the Z scale, or that more abbreviated scale. So if you look on their website, they have a program called STEPS, which is to help improve either your practice or your personal resiliency and some of those things. So getting a little off topic, but it is very real. It's well defined, I think well recognized, and there are some validated scales. Clarissa, I know that we've used some, at least here in the Avera. I know at Avera McKinnon, Blake, I don't know if you guys did in Aberdeen, but we have polled our physicians. Sadly, one of the things we do know is that medical students going into medical school actually appear more resilient than the average population. Within the first year of that medical school experience, they are less resilient and showing signs of burnout within that very first year. And then we run at about almost a 50% clip of burnout through medical school into our careers. So those are pretty shocking and sad statistics. But I'll stop there and let you take the mic.
Yeah. So Blake, I was curious, you work in a smaller community, and you have a smaller group of hospitals to take care of a wide catch area. How do you and your colleagues cope with this? Because I used to work in a critical access hospital in South Dakota, and the responsibilities were enormous, and it seems like everyone just has infinite amount of expectations for you in these smaller towns. What have you recognized with you and your colleagues, and how are you guys doing?
Well, I think that one of the things about being in a smaller community is that oftentimes when you're in a room with leaders in the community, you're talking about things that I have a certain expertise in a small area. A lot of times I get questioned on things that I don't really know the answers to, and I think that they're good questions as well. But yet, I'm still put in a position where I'm expected to lead when I may not necessarily know what the right best answer is. And so, for me and my group, the way that I've chosen to be a leader with my group is to, you know, obviously ask for input from everybody else around me. So we've had quite a bit of flux in my group as well. We've had quite a bit of turnover where we lose physicians probably every 3 years with turnover. And so trying to find ways to make sure that we all mesh together is important. And I think the best way to do that is to ask for input from everybody. But as far as the level of burnout, you know, burnout is such a broad topic. It means different things to different people, and it even means different things to me at different points in just my 5 years of working in Aberdeen. You know, we talk about the mental, the physical, even the spiritual sort of fatigue in all of this, and there's so many different facets of how that all blends together as time goes on and sort of morphs and evolves. One of the things that I like about being a hospitalist and being in a smaller group is that we can all come together and talk and have a good dialogue about what each of us is kind of going through. And so we kind of develop that sort of camaraderie amongst ourselves. And I think that's really helpful for me to clarify what the big questions are and what we're trying to do as a group, even when it comes down to a patient's care. So it's challenging, but it's enjoyable when you have a group that you can connect with. So.
Yeah, I remember, I think a lot of people go through burnout personally. I remember seeing one of my colleagues, you know, I don't see too many colleagues retire anymore. They never make it to retirement age, but there's one in Hawaii that retired and he told me, I'm never touching medicine again. This is my last thing. Never going to renew my boards, never gonna look at anything medical. I'm done with this permanently. And you know, you would think someone who devoted their whole life until age 65, you know, would still have a joy. But you know, I'm seeing even people who are much more senior than me just completely fed up with things. It's amazing. Yeah. So, Dr. Stanley, does burnout actually lead to depression, or can it lead to depression? Is there anything that suggests that?
Yeah, it definitely can, and I think that's one of the most serious risks. I mean, there's several consequences that have been identified with burnout. I think depression. Jennifer actually mentioned the most traumatic one. We know that you know, we lose between 300 and 400 physicians to suicide every year, and women particularly are about 140% at greater risk than the female population in general. So so women physicians are at even greater risk. So I think there's a very clear correlation. So that doesn't mean that every depression and suicide is related to burnout, but I think that without a doubt, it's the particular stressors that lead to depression are the same, if not planted by burnout. It's very similar in terms of how it evolves. And I think too, just like you mentioned, you can kind of move in and out of burnout. I think physicians through the course of their career can move in and out of depression. And sometimes just as the causes are very similar, some of the effective coping skills are very similar. But again, I think the things that are concerning about depression in our profession are we're hesitant to seek help. We're hesitant to acknowledge it. And to some degree, we've been, you know, talking the talk, but not walking the walk. Clarissa, I give her great credit for just within the last year or two, getting the board to at least change the questionnaire on our licensure
May of 2020. Yeah.
There we go. Yeah. So that's very recent, and thanks again. So yeah, if you recall obtaining your licensure here in South Dakota, it asks you very, I think, it made you feel like you'd done something criminally wrong if you had sought help for a mental illness or had treatment. So that is changed. I can't believe that it was on every one of our minds if we thought about seeking any kind of help. So just one, but that's, I think, just one kind of example of how there are a lot of things we're concerned about. Even with the improvement in licensure, I think people are still concerned about impact on license and impact on professional standing, impact on continued ability to practice at the full scope of your licensure. We're all afraid of many things within here. And then, just like Blake, and I think it's even harder for folks in smaller communities, because where could you go for help that you wouldn't be immediately identified?
Right.
You're like a local celebrity if you're a physician and everybody knows what you do all the time. It's probably not, it's better in Sioux Falls, but not a whole lot better, because within the health systems, everybody knows who we are. And we haven't done a good job as psychiatrists, I can speak for my own, at kind of having unidentifiable places to seek help. So we talk about one of the risk factors, I think, in our profession, in physician care, is we don't provide good enough access corridors. So we have access, but am I going to make you walk into my office, meet with my registrar, who may be your primary, you may be her primary care physician, and tell her I'm here to see Dr. Stanley. That's just extremely difficult on so many levels. So that's Eric, that's just kind of the tip of the iceberg in terms of some of the barriers that we face. So yes, burnout, I think, clearly leads to depression, and depression is frighteningly lethal in physicians. And we have a long way to go to try to prevent that and provide better access and better opportunities for wellness. There's a whole conversation, and hopefully we'll get into it too, I think, about wellness and self-care and some of the things that we need to promote amongst each other. And then there's organizational approaches that I think we need to encourage.
Right. Now, Dr. Williamson, I know you used to practice in Brookings, doing the traditional physician, essentially doing everything: skilled nursing facility, hospitalist, primary care. Do you think, with all that demands in your life, do you think that caused you to burn out and change your job description to outpatient only?
Yes, can you hear me?
Okay, now I can hear you.
Can you hear me? Yes.
Right, we can hear you now.
So you're quite right. The question that yes, that was quite one of the decisive factors why I switched to outpatient medicine. I said to myself, when I heard what happened to my friend a little over 2 years ago, and when I said friend, I was, for 2 years, 2 consecutive years, when I was in New York, I was the delegate for the CIR for several hundred residents. I would go from hospital to hospital, different specialty, and I represent them, bargaining union and all. So I got to know these guys personally, and then to see that someone who you could sit and eat and drink with could be so burnt out that they ended up in that, taking your own life. It dawned on me when I was doing the traditional model, working in hospital and then in the clinic. You'd be in the clinic, and then the nurses will call you that there's something wrong with your hospital patient, and then you have to apologize. I can control this by choosing whether or not I want to practice like this, I don't have to be pretending that I know how to deal with burnout, because in New York, we were given lectures on burnout, and we have all kinds of programs, and we will go as delegates and encourage and meet with residents and all that. I'm like, but how is this applying to me? I'm beginning to feel irritated when they page from the hospital that I'll be in the office with my clinic patient and I have to be running back and forth. So I was getting more irritated, not depressed. I was getting a bit ticked off, or you can use pissed off, whatever. But I was quite annoyed. And that was the first sign that, look, you need to do some self-care. So I took a vacation and I came to the Yales and I inquired about an outpatient opportunity, and then I made the change. Now, outpatient is not just, oh, it's a nice pie in the sky kind of experience. At least you have regulated hours. A lot of it is paperwork, so that's a different level of burnout. But the back and forth dealing with the traditional model, it's very, very distracting from outpatient to the inpatient setting. It's a very distracting. You can't really focus 100% on giving care in any one setting. You're always distracted when you're in one setting. So that to me was a source of burnout. So in answer to your question, yes, that kind of model, while it has been practiced by physicians for ages, and while I felt shame in thinking that colleagues who went on before me held their own, I got to the point where I said, well, no, I am out of here. I'm going to choose what I am able to do because I only live this life once.
Right. Yeah, I was doing that traditional medicine model for 2.5 years in a small critical access hospital too, and I don't know how people have been doing this for many, many decades. And to all the doctors who are there, they're usually much older than me, 60s, 70s, and to them that's like normal. And I'm the weak sauce here in town, like cannot handle it. But it's just not conducive for health, especially. I mean, just that work-life balance, I think, is extremely important. And when you don't have a distinction of work and home, it's just really poisoning to the mind of you just can't separate and concentrate on things that you want to.
So Eric, to your point, I think that that work-life balance was not an expectation, right? I mean, I'm the child of a physician father, and let me tell you, there was no expectation that he was going to make time to go to plays and what, you know what I mean? Like he lived at work, and that was sort of the way I think that a lot of physicians of that generation just sort of expected it. And you find a lot of people, men and women alike of our generation, saying, look, I want to spend more time with my family. I really want to spend more time doing things that are, not just work all the time.
Right.
So part of it, I think, is, expectations. It's not that I don't want to say that we're weaker. I think we just have, there's changing priorities in generations as time goes on. And I think it's very reasonable to say, look, I want to do something else other than spend, 90 hours at work every week. I think I'm a better doctor, actually, when I spend not all of my time at work, ironically, because I'm a better, more well-rounded person.
This is Rob Allison in Pierre. I'll tell you, I've been here 22 years in Pierre now, and it's interesting because when all of the requests came to have more time off, those were the same requests I had and wanted 22 years ago. It just wasn't able to do it when you had 4 internists to cover the hospital. And so it's funny when people say, I want this, I go, I wanted that 20 years ago, but we just didn't have the capacity to do it at that time. So you're right, Erica. Does it go back to the guys who wore the suits and went to the ER and did their own work? That's Jim Teason in Pierre, and that's what he expected to do, and that's what his patients expected. But I came to Pierre 22 years ago with Phil Meyer, and we said, you know what? Let's alternate weekends, 1 and 4. And that was a novel approach there, that I would see everyone's patients on the weekend because we're all productivity driven and you're worrying about paying your bills and covering your overhead. But that was the first part to our mental health. And then it came the ER and the evolution in rural Pierre, South Dakota, a town of 12,000. And Clarissa's well aware of that.
Yeah.
And it continues to evolve into, different things. Now I only do clinic work. I did 13 years of inpatient, outpatient, starting at 7, getting to the clinic at 10 o'clock some days because I had 5 admissions or 2 people overnight or had to take care of the heart attack. Everyone had to change, but it's been good in some ways, the hospice program, to allow us to partition our jobs as physicians. And that's actually helped some of my mental health as a outpatient physician as well. Do I miss it? You bet. I miss the intensity and some of that at times. At the same time, they're both challenging to recognize the workflow. So.
Thank you, Rob. Yeah, that's very insightful. I'm glad Pierre was able to kind of move to a more modern model, and I think having outpatient and a hospitalist program is very key to kind of separating that.
Maybe should we switch a little bit from sort of the problems to talk a little bit more about solutions, maybe, because I know that for people who are like, yes, I agree, I'm, I have burnout, or I don't think that things are quite right, like we want to give them some options. So maybe we can sort of shift to, like, now that we know what we know about, burnout and mental illness in physicians, like, how should I as a physician approach the idea of making a plan or prioritizing to make sure that I stay well? Like, what things do I need to consider when planning out, my job or my life or my, personal and mental well-being?
All right. So I think that's a very important thing. I think the hardest part is sometimes we feel stuck. We feel stuck and we feel powerless. I don't have control of my schedule. The clinic administrator or the CEO tells me how I run my practice. I think that feeling of lack of autonomy, just tons of paperwork, it really starts to build up. And I guess, what are your thoughts, guys, on say you really love a physical place and you want to be there, but just the current job is not very conducive to your mental well-being and mental health. What are your guys' thoughts on how to better this, or what can we do, or what do we have in control?
Well, I can speak to that, I think, a little bit. Knowing that going through the middle of my search in Aberdeen here, our search here, I knew that Aberdeen is a place where I wanted to stay. Yet halfway through our search, I was realizing that this isn't going to be. I don't have the stamina to keep up with the pace of what I'm witnessing here in the hospital. So recognizing that, I knew even beforehand that when our search hits, I'm going to have to be kind of extremely disciplined about the basics, making sure I get enough sleep, making sure that I'm eating healthy, and making sure that I'm exercising. You can't, unfortunately, sidestep those crucial aspects of it. You got to get your frontal lobe in the right place. And be prepared. If you're not well rested, you're not going to be able to handle anything well. And so I got pretty disciplined about my plan and how I was going to approach that. But knowing that I still was dealing with the number of patients, the intensity of the situation, and knowing that it was only going to get worse. I was still dealing with sort of the emotional trauma of the situation altogether. And you can't get enough sleep to just deal with the emotional trauma of COVID in situations like that. So what was helpful for me was to go back and realize what it was that got me into medicine in the first place, and knowing that I needed to find a way to make time to be able to sit down with my patients and connect with them again, and to reestablish that connection, and be conscientious about not going from room to room to room, just making sure that the basics are in order and getting my work done, but actually establishing a connection with the person in front of me really went a long way. And then for me, at the end of the day, while I might have been exhausted, I needed to write. I needed to sort of reassess the decisions that I made during the day, and sort of reevaluate how I did my day well, and what I could have done better. And again, some of these things sound so cliche when I say them out loud, but there's really no way around them when you're dealing with the intensity of the situation such that it is.
Right. I think you bring a very important point. We have to make time for our own well-being, eat right. Sleep is so key. exercise. And I think a lot of physicians just feel so busy, they don't really get the time to do all that. And when you're running on low fuel, start another long shift. And I agree with you. I've never had so many goals of care conversations in one single week. And, you know, there's no family members. So you're spending all your time calling every single family. It was emotionally draining. You're right. The medicine part wasn't the hardest part, but there's just the emotional and you know, you kind of feel powerless because this is a disease we just don't have real good treatments. We just watch and wait and kind of encourage and really be there for our patient. And I think you bring the essence of finding out our true reason why we're in medicine and trying to captivate and anchor on that, so that can help keep us going through to these hard times. Clarissa, do you have any insight? I know you do a lot of physician wellness along with Dr. Stanley. What other good methods can we do as physicians?
Yeah, I mean, it's funny. You find, especially on like social media, like you'll find physicians who clearly are not in like the best place, and then they'll sort of throw things out. And you're like, well, I've got job A or job B, and like, which one should I do, right? Like they always want like help choosing how they can find a way out of this, like a situation where it's the job or whatever. And it's like, I don't know. I spend so much time telling people that I know or people that I don't know, other physicians, you know, like there's no way that anyone else can tell you what job to pick. There's no way anyone else can tell you where, you know, the best place for you to practice in terms of like outpatient or inpatient or traditional or whatever. Like it's literally impossible for me to tell you what you should do, because what you should do is really tied to your core values, and you really have to know. You know, Blake said, I mean, he identified one of his core values when he was talking. Like it's very important for him to sit down and have meaningful connections with patients during the day. He will never be happy you know what I mean, unless he can do that as part of his workflow. He doesn't need to do it every minute, right? Like there's other stuff like documentation still has to get done.
Right.
But if he can't make time in that, then that job's never going to work out for him, right? Like it just won't.
Exactly.
But that's not the thing for everybody. For some people, you know, it's about I need to have time to teach. Like it's really important for me to teach the next generation of students. And if I don't have any opportunity to teach, then I feel like I'm not, you know, aligning with my core purpose. I mean, you look at what burnout is, and one of those tenets is like, if you don't feel like you're doing a good job, right? Like that's burnout. And if you need to know what you think a good job is to really tie into what you should be doing. So clearly there's a lot of societal and healthcare issues surrounding burnout, but I think the easiest thing when it goes back to that comment before about control is you can control where you practice though, and you can control what kind of medicine you do. That is within your ability to change. And I think you really have to do a lot of soul searching, and you can do that yourself, but sometimes having a coach can help you sort of, you know, reflect back a little bit and help you figure it out if you're not sure what that is. But I think that, you know, that little bit, and then obviously you know, you got to eat and drink and you know, take care of your bodily functions and that sort of stuff are also very important. And then you have to find somebody, you know, in your life who is that mirror for you, that can, when you're not doing well, that is the person who's honest with you and tells you that, because you may not realize it for yourself. Like I think every time in my life where things have been like not quite right, like I'm not the first one to figure that out. You know what I mean? Like usually for me, it's usually my husband, honestly. He's the first person to be like, you know, you've been a little like not yourself, like have you run in the last week? And then usually I'll be like, no, I haven't run at all. And he'll be like, well, maybe you need to use the treadmill, because use the treadmill, please. But you have to be open enough with people to like accept that advice and help too, right? Like if you have somebody who's trying to tell you those things, but you keep shutting them out because you think that you don't need anyone's advice or you don't need to take any, you know what I mean? Like then that sort of closed offness just sort of puts you in trouble, and then, you know, leads to other sort of bad consequences. So I don't know, that was a lot of things, but identify your core values, do all the things Blake said in terms of, you know, food, drink, sleep, and then identify someone who is, you know, aware enough of what's happening in your life that they can sort of reflect back to you when things are not going well. Then you have to be sort of open and vulnerable enough to sort of listen to what they're telling you.
Right.
Yeah,
Very good advice.
If I could jump in there, Clarissa, I think very well said by both you and Blake. And I think one of the things you mentioned is you know, there's no prescriptive approach that works for everybody. Although what you talked about was things that are universally applicable. Blake, one of the things you said, you know, is, you know, it sounds cliched, but honestly, it's what we tell every patient when we're talking to them about managing their illness. We're just not very good patients. We think it applies to everybody but us. So that work-life balance, that ability to maintain our physical self is critical. You can't, I don't care what your illness is, whether it's psychological or physiological, you're not going to do well unless you're taking care of those core things. And Clarissa, I think, you know, everything you said was critical. And maybe one of the most important things is to have that person of trust that you talk to about where you're at. And not always for them to be the harbinger of, hey, you're out of line, you got to get, but just the ability to, as you said, mirror or bounce things off or discuss. I think, you know, one of the things that's difficulty with burnout is there are kind of what you mentioned, there's things that are under your control and things that feel like they're out of your control. And some are about your personal environment and some are about your work environment. And things like the EHR and how facile I am with that tool, I can probably get better, but honestly, without some help, it's incredibly time consuming to try to figure out how to do that. And so I think there are the things we can do for ourselves. And then there's the things that we need to work within the structure of our employer, or, you know, if we're self-employed physician, we've got to sit down and look at better processes, better ways to do it. That's frustrating. But I do think as we look at wellness programs, we kind of talked about this a few weeks ago, Clarissa, but I think a lot of wellness programs are focusing a little bit more on that environment of practice, where a lot of what you've heard in the previous years was about creating resiliency and improving self. And that's great. It is critical, but it still only manages a part of what's leading to burnout and a part of what's leading to people leaving, to your point, Eric, leaving the practices early, you know, just no more joy in this. Because honestly, a lot of the joy that's been sucked out. And I was just, interestingly today, as I was going through my email, I actually got one of those Medscape 2020. So what they do well is they put out some interesting surveys, right? So they had surveys of physicians in burnout. Yeah, so don't read all the articles, but anyway, the surveys.
Data is good.
Yeah. But anyway, so they had a whole section on burnout and you know, by age and sex and all these practices and all these things. But one of the ones that caught my eye, and I printed off, I've got it here in front of me. But what contributes most to burnout? Number one, too many bureaucratic tasks, charting, paperwork, as examples. So those are things that I don't care how much you take care of yourself, that doesn't change. That's still a piece that's going to frustrate the heck out of you. Number two is spending too many hours at work. And that, you know, compound that by how many people I know that go home and work from home. So you put in your work hours, your home time doesn't even count as off work, you know. So that's a horrible situation to find yourself in. But that's, you know, that's where I think you have to have just very frank discussions within the organization. Find a champion and your administrator, or find colleagues to kind of give you a broad enough voice to try to precipitate change. And I would say, Clarissa, we talked about this before, but I in other venues, I think you also have to know, and you kind of alluded to it, the difference between maybe when you need a coach and maybe when you've gotten to the point where you need to go to a professional counselor, maybe even a psychiatrist, because it's beyond burnout. And it can be that's probably a tough line to know if you've crossed or if you're wavering over. But obviously, anytime that you feel thoughts of suicide or hopelessness, or, you know, I'm going through the motions and there's absolutely no joy left in life, certainly those are indications for you. And if you sense that in a colleague, one of the things we have to do to change our entire culture, because I'm big on, you know, I think our medical, we have a wonderful profession and we have incredible people that have gone before us, but they weren't very good at this part. So we are remaking a culture as we evolve through our careers now. That is a culture of caring within our profession. We're great at caring for others. We got to learn to care for ourselves. So I think those are discussions we have to start having, and we have to look for those warning signs in others. And so it is that, extreme loss of function, can't sleep, sleep too much, no joy, hopelessness, thoughts of suicide. Those are the risk factors. And if you see it in a partner, because that's part of what we need to do, and you're not comfortable, find somebody that maybe is closer to that individual and have them talk to them. It's so often just saying that those first words, I'm concerned about you. I just want to know how you're doing. Can we have a talk? There's even some scripting. We talked about that AMA site. If you go in there, there's even some scripting about how to address a colleague you think is struggling. So that's a little deeper than just talking about burnout, perhaps. But I just to encapsulate, like Clarissa did, I think there are two buckets, and some of the highest statistical reasons for burnout are really things you almost have to work within your system. It's interesting, though, that private practice physicians, solo practitioners actually have a higher rate of burnout than system level. And I think it's because a little bit of what Blake was talking about, just that, everything rests on you, and you probably just don't know how to shut things off when you need to get away. But I'll stop there. I think very good contributions by everyone.
Yeah. All right. Well, thank you for that insight. When I was in Hawaii, I still remember already 1 year out of residency, almost every day I started thinking, what can I do with my medical degree that's not this? And I was like, how? And then I was thinking to myself, how did I even get here? To think that I spent my whole life doing this, and now I'm thinking, what can I do with my degree? And I guess, I agree. Physicians are extremely resilient. I did that for 3.5 years. And then there's some things out of our control. The bad boss, there's nothing you can really do about that. And I was stuck with one of those, and all the bureaucratic tasks. Not only did I have 22 appointments that I had no control of, there was a billion phone calls that you had to do, telephone appointments, they called it. So I was doing telemedicine way before all of this stuff. And actually my therapeutic approach was just uproot, and that's how I ended up all the way in South Dakota. And that change was actually very invigorating for me, to clear my mind and fall in love with medicine. And I think you're right. There's some things we can change, and if we are sensing that they're just things completely out of our control, let's not keep perpetuating this in our own life. We do have control. It's just sometimes we have to make that big change. That is, not easy in the family, but everyone's going to be much happier if you're happy in the family. Right. Any other closing comments from anybody?
Mentioned South Dakota Health Professionals Assistance Program, and SDSMA is working on. There's some new legislation coming through, and that is actually, I was just talking to our Deb Fisher Clemens, our political liaison, today about that, Rob. But I would say those programs, if you're not familiar with them, it's primarily been for people that have some addiction issues, and gives them, or is intended to give them, a safe haven for recovery. Rob had just questioned, what's the role and how important are they, and how valuable are they? I think they're exceedingly important. One of the other things that we haven't really talked about is burnout, depression, and work stress to lead to addictions. And some of us are more genetically inclined toward that, or family history would incline us toward that. So it's another mental illness that claims a lot of our practicing physicians every year. So those, the success rates in those health professionals assistance program is like 95%, far, like basically 3 times the success rate of community practice recovery programs. So they're very powerful, and I think they're incredibly necessary and incredibly critical to us. And another one of those things we as a profession have to support, that idea that, it's an illness just like any other illness. And when we have a colleague, they have to be able to maintain a safe practice, but we can also rehabilitate them through these kind of programs and get them well again. So very important point.
Clarissa, any closing comments for us?
Oh, sure. I think to Dr. Stanley's point, I think when things are very bad for you personally, it's very hard for you to do anything else other than sort of focus on getting better, whether that's, getting out of burnout or helping your depression or whatever it has to be. But I think for those of us that maybe are like, look, maybe my burnout's mild or I'm a little unhappy, like it can actually be really therapeutic to lean into helping your colleagues, that it actually can help you just as much as it helps them to say, look, this, task is part of, what stresses me out of my day. Let me advocate to the system to change it. Or, hey, this rule is really unfair and it helps prevent me from seeing a psychiatrist. And I think that I need to do that. Let me advocate to change the rule. Like whatever it happens to be, standing up for your colleagues actually can be very therapeutic for yourself, as well as sort of, the people who need us, need this help the most are the people that are going to be the least able to do it. Dr. Stanley talked about, changing the rules with the board. I mean, the people who really needed those changes were not the people that could stand before the board and say, please change it. I need to see a psychiatrist and I don't want you to have to know about all my medical business. It had to be other people, us to do that for them. And so even if you feel like you're in a good space, that doesn't mean that you don't have a role in advocacy and trying to move the needle of changing medical culture forward. In fact, you're more needed because we really do need everybody to sort of be on the same page, that we want this profession to be something that you can do for your life. We feel like it's a calling, so let's make it a calling that everybody can continue doing, because we can't afford to lose colleagues, people that we know and care about, to suicide or to just leaving this profession because they can't do it anymore. We need all of us, and so it's going to take all of us to keep us there.
Wonderfully said. Well, I think we probably should wrap up here, but I want to thank all of our guests. Thank you, Blake, Matt, and Jennifer, for taking your time out and joining us today. I really enjoyed our discussions, and yeah, everyone stay safe and let's help each other, stand our ground and help each other, power through this pandemic together.
Really appreciate you guys coming tonight. Thank you for your comments. Very, very helpful. We'll have this up for other people to see and I think benefit from your wisdom. So thank you.
Thank you.
All right.
Thank you.
Thank you. Good night, everybody.